Hello, my name's Simon Monkhouse. I'm a consultant upper GI surgeon based in Surrey, and I want to talk to you today about heartburn and heartburn surgery. So, lots of people will experience heartburn. There is a degree of normality to that, and we call that physiological heartburn. So, if you have too big a meal or you have lots of spicy foods, it's quite normal to get a bit of acid going up into the food pipe and giving you an experience of chest pain and discomfort. And that's considered normal. So, that's not the type of problem that we're trying to treat here. What we're trying to treat is the patient who has daily heartburn, even when they're not eating, and it is affecting their quality of life. So, heartburn is a condition that is a big spectrum. So, most of the time, a doctor won't get to see a heartburn patient because they will have gone to their pharmacy, picked up some antacid pills, and tried that. It's only at the point of that treatment failing that the doctor will normally see their GP, and they may put them on some prescribed medication. If that doesn't work and the condition is still ongoing and affecting quality of life, then often a referral to a surgeon will be made. This is because medical treatment has failed or is considered to have failed, and we need to think about how we can help this patient. So what we would generally do is do some investigations into what is happening and the current state of the situation for that patient. So the types of investigations that we would generally do are threefold. The first one is called a gastroscopy, which is a camera down the throat, usually under sedation, so you don't know much about it. And then this gives us an opportunity to see what's going on in the food pipe and the stomach. Often we will pick up something called a hiatus hernia, and I'll explain what that is in just a second. The other benefit of the gastroscopy is we can see what level of damage has occurred from excess acid. So, has the patient got ulcers or erosions or red inflammation? We can also do a test for a certain bacteria in the stomach which predisposes you to excess acid. And if you have that bacteria, we can treat it with antibiotics. So the gastroscopy is the first line investigation, and this will give us a really good feel for what's going on. We then often do something called a barium swallow, which is where we give you some special X-ray drink to drink, and we will then do a series of X-rays while you drink that drink. This allows us to see what happens in real time when drink or food hits your stomach. Does it stay in your stomach, or does it come back up into your food pipe and into your throat? This will give us a functional view of what's going on. The third test that we often do is a 48-hour pH study. So we are looking for how much acid is going up into your esophagus over a 48-hour period, and seeing if there's any association with your symptoms. So what we want to see, if you are going down the surgical route, is that your symptoms correlate with when you have excess acid. So if you're getting symptoms of chest pain or heartburn and you're not having acid detectable in your food pipe, then it may not be an acid problem and there may be an alternative diagnosis. But more often than not, we see your symptoms being reported when you have abnormal acid. And that test gives us a score. It gives us a computational analysis of what's going on, and you get a score. And if your score is over a certain amount, which is 14.7, then you are considered someone to have what we call pathological heartburn rather than physiological and normal heartburn. And if you have pathological heartburn, we can talk about surgical treatment. Now, I mentioned earlier about hiatus hernia, and this is really key with what's going wrong in patients with heartburn. So, a hiatus hernia is essentially where the diaphragm, which separates the food pipe from the stomach, opens up. And that is your hiatus hernia, is the opening up of the diaphragm. This allows the stomach to go up through the diaphragm into the chest cavity. Now, it's not there all the time, but when you're under stress or you're coughing or eating, the stomach can bob up and down through the diaphragm, and its normal restraint mechanisms to keep the acid down below the diaphragm have gone, and you have uncontrolled acid. And that's what a hiatus hernia is. So if you are somebody who is going to have surgery for this condition, and this means that you're right at the end of the spectrum of the heartburn spectrum, then the primary aim of the surgery is to restore the stomach back to its normal position and close the diaphragm. So that hiatus hernia needs to be stitched closed, and sometimes we use a mesh for that, but very rarely. And then we need to anchor the stomach into the abdomen and fix it in position. We also create a new valve to stop acid going up and but allow the food to come in, and that's called a fundoplication. So you may see online the term fundoplication, and that's the process of creating a new valve to stop acid going up. So the principle of the surgery is repair the hiatus hernia, create a new valve, and ensure the stomach is fixed in the abdominal cavity. Sounds like big surgery, and it is big surgery, but we can do it as keyhole, and usually it's just one night stay in hospital. Sometimes we can even do it as a day case. So although it's a big operation, the recovery tends to be quite quick, and we should be able to get you back to normal function within 2 weeks and back to normal eating within 4 weeks. So there's a lot to discuss when we talk about this surgery, particularly around the risks and the consequences of complications, etc. And then you will be given an opportunity to determine whether it's the right choice for you. And you'll never make that decision on the spot. You'll just go home and reflect, discuss with your family, and reflect on the literature that you're given. So that, in a nutshell, is heartburn surgery. And probably around 2 to 5% of the people suffering with heartburn end up having surgery, because it is really just for those end of the spectrum patients whose quality of life is so miserable that by their symptoms that something needs to be done. So most heartburn is managed without surgery and without surgeons like myself, but for those 2 to 5%, we can really help you.